My name is Molly Williams, DMP student at Maryville University, and this is my presentation on my DMP project, The Efficacy of Phentermine for Weight Loss Compared to Diet and Exercise. I would first like to acknowledge the committee members involved in this project. That is Dr. Amanda Flynn, Project Chair, Dr. Jennifer Brunworth, Faculty Committee Member, and Dr. Bruce Barker, Community Committee Member. Obesity is a growing epidemic in the U.S., where it is reported that 35% of adults have a BMI considered obese. We are aware that obesity is a risk factor contributing to chronic conditions, which include but are not limited to type 2 diabetes, cardiovascular disease, and some cancers. As the number of adults in the U.S. with obesity increases, there has been increased focus on the treatment of obesity and weight loss methods. A modest weight loss between 5 to 10% of body weight has been associated with decreased risk factors and decreased risk of chronic conditions associated with obesity, even if the individual still has a BMI, which is considered obese or even overweight. Although calling this a modest amount of weight loss alludes that this may be easy to achieve due to being a smaller amount of body weight percentage, it is very difficult to lose weight. Behavior changes such as diet and exercise are always the first interventions recommended for weight loss, often due to obesity being a complex and multifactorial disease. These changes are not easy to comply with. Pharmacological treatment has been shown to improve weight loss in combination with diet and exercise. And although medications are available, statistics show that they are not often prescribed, and the reasons given for not utilizing these anti-obesity medications by providers include not viewing obesity as a disease, the misconception that obesity does not need treatment, and decreased comfort and lack of training with prescribing of these medications. In 2013, the American Medical Association announced their recognition of obesity as a disease, requiring treatment after a vote from their House of Delegates. They recognize both the need of treatment and prevention for obesity as a disease, and it is important that we recognize this treatment in our current practices as well. Comparing the weight loss with and without phentermine will show the increase in weight loss when the anti-obesity medications are combined with diet and exercise. The outcome of this research will not only compare the difference between weight loss with use of phentermine, but will also help us target the patient population who may have the most benefit from the medication intervention. We may also establish appropriate risk factors to determine the patient population not appropriate for this management. Showing the difference in weight loss with interventions will also provide data to educate providers on different treatment of obesity. And the intent is to increase their comfort in both recognizing obesity as a disease and the treatment with appropriate interventions. When reviewing literature for this project, there were 4 common themes discussed throughout the literature review. This includes barriers in obesity treatment. Barriers were reported by healthcare providers as reasons for not treating obesity, including lack of comfort, lack of knowledge of the medications, fear of medication side effects, and belief that they have little efficacy in providing weight loss. Many providers reported that they're not familiar with anti-obesity medications, they have lack of time to discuss, they have lack of comfort with treating obesity in general, they have bias for treating obesity, they're worried about adherence by patients, and lack of coverage by insurance and reimbursement. They report all of these as barriers to obesity treatment. Concerns regarding the long-term safety of pharmacotherapy for weight loss have also created barriers, limiting their clinical use, especially the medications with significant adrenergic actions or central appetite suppressing actions. It is recommended that providers further educate themselves and approach obesity treatment with more knowledge by continuing education and even certification by the Obesity Medicine Association. If providers are still uncomfortable with treating obesity, it is then recommended that they refer patients to those who have obtained this certification to initiate the treatment. As we increase the understanding of obesity treatment, the management will then meet the standard of care for other chronic conditions. Another theme reviewed was current obesity treatment. There are conservative treatments of obesity, which include diet, exercise, and lifestyle changes. Lifestyle modifications continue to be initial management, but is often difficult to maintain long-term weight loss with exercise and diet alone. so patients do not achieve long-lasting weight loss with lifestyle modifications. And they have difficulty with adherence and a physiological and neurohormonal adaptation of the body in response to weight loss. Multiple dietary approaches, pharmacological and surgical treatments are currently available to treat and manage obesity. Treatment goals should be individualized, but include long-term weight reduction, improve obesity-related risk factors, and reduction in obesity-related disease, lowering mortality. The United States Preventive Services Task Force recommend that an intensive, multifaceted intervention program for obesity treatment is included for all obese patients. An additional theme reviewed was the pharmacology treatment for obesity. The use of pharmacology is appropriate when lifestyle and behavioral changes are ineffective and should be included in all obese patients combined with diet and exercise and lifestyle modifications. Treatment should be individualized for the patient based on their medical needs, but it is used to improve the neurohormonal dysregulations that cause weight gain and prevent weight loss maintenance. A decrease in leptin and increase in ghrelin creates a higher weight set point that the body returns to after weight loss, and the pharmacology targets the set point, regulating these hormones and supporting weight loss and maintenance long term. Pharmacology should be considered for patients with a BMI greater than 30 and those patients with a greater than 27 BMI with weight-related comorbidities. When patients have failed to achieve weight loss with lifestyle modification approaches or have difficulty maintaining weight loss, pharmacology is the next recommended approach. In the studies reviewed, weight loss medications were associated with more weight loss and maintenance over 12 to 18 months than those randomized to placebo, and at least 3% of body weight was lost in those patients, which is an amount of weight associated with improvement in both glycemic and lipid profile in patients with obesity. Almost all the bariatric specialists studied reported using medications for their management, and they reported using phentermine as the most prescribed medication. The next theme was weight loss with use of phentermine reviewed. Phentermine is the most prescribed anti-obesity medication in the US and was originally approved in 1959. Although only approved by the FDA for short-term use, it is frequently prescribed off-label for more extended periods by specialists treating obesity. But unfortunately, there are few controlled trials of phentermine monotherapy for more than 6 months due to those FDA regulations. The concern is that FDA compared phentermine to amphetamines back in 1959. So it is still often compared to amphetamines, which has a similar chemical structure, but it is actually different. And it does not affect the secretion and reabsorption of dopamine such as an amphetamine does. Therefore, phentermine has a low chance of substance abuse or misuse. And the concern that phentermine induces abuse or psychological dependence in overweight, obese, and weight loss maintenance patients is a barrier to prescribing this treatment. There's also concern that prescribing phentermine increases blood pressure and heart rate, which would then increase cardiovascular risk. But data actually shows that the patient's blood pressure declines from baseline, showing that weight loss with phentermine treatment is associated with favorable shifts in blood pressure and even slowed progression of hypertension in those obese patients. Phentermine is also the most cost-effective pharmacology option and results in the most weight loss in the first year of treatment compared to other medications. Grohl and Grimshaw's framework for changing behavior translates evidence into practice by reviewing ways to implement change. Their framework for behavior change suggests identifying the target group, what needs to change, and the barriers to change. Then identifying the interventions needed for change, implementing, and evaluating the results of the change. This project was conducted by utilizing a 5-step approach guided by the framework for behavior change. The first step in this process includes identifying the improvement goal, which is improving the treatment of obesity by providers with use of interventions. The second step includes identifying the target population and target setting, and this includes obese patients in a weight management program. The third step includes selecting the intervention, which is the treatment of obesity with use of phentermine in combination with diet and exercise. The fourth step is implementing the intervention, and this includes the intervention of phentermine treatment combined with diet and exercise over a 12-week duration and collecting that data. And the fifth step is the evaluation of the results and translation of evidence into practice. And the data collected includes weight, along with other metrics to determine improvement of overall health and quality of life. And those metrics include blood pressure, heart rate, appetite, energy level, cravings. The purpose of this scholarly project is to compare the weight loss with use of phentermine with patients in our weight management program compared to the weight loss without use of phentermine in the same patients. This is of importance because it compares literature and provides data to support a multifaceted approach to treating obesity. It also targets the patient population who may have the most benefit from the medication in the future. It also provides data to educate other providers on the treatment of obesity, and the data increases provider comfort in both recognizing obesity as a disease and treatment with appropriate interventions. This project is a retrospective study conducted in a single weight management clinic. Patient data was evaluated at baseline and then after 3 months of only diet and exercise intervention. Data was also evaluated after 3 months with intervention of phentermine diet and exercise for weight loss. Body weight, blood pressure, heart rate, those were recorded based on the appropriate intervals. Reported energy levels and appetite control were also collected by patients, reported on their questionnaires at each appointment, and then transcribed into the visit note by the medical staff at patient's appointment. This information was collected from the EMR during the data collection of the retrospective analysis, and the vital signs were collected from the EMR, which were evaluated at appointments by measurements using office scale, blood pressure machine, and the reported energy levels and appetite control were assessed by questionnaire at each appointment, and the patient was given the same questionnaire at each visit. Patients were asked at each visit if their energy levels were good and if their appetite was controlled, and they would answer by circling yes or no. These questions and answers were recorded in the EMR and evaluated when collecting data for the project. A convenience sample consisting of 100 patients from the weight loss clinic was evaluated from July 2018 to July 2021. Data was evaluated at baseline, then after 3 months of diet and exercise alone, and then after 3 months with intervention with phentermine diet and exercise for weight loss treatment. Inclusion and exclusion criteria were evaluated before the sample population was determined and data was collected. Participants were identified based on inclusion criteria, and this was identified by accessing medication records using the electronic medical records. And a total of 417 charts were reviewed before a sample of 100 was identified meeting all appropriate criteria for analysis. And in the sample studied, 68 of those were female and 32 were male. Ages ranged from 18 years old to 69 years old. The patient's weight loss with use of diet and exercise was compared to the weight loss with use of diet, exercise, and phentermine, and both data sets were run for a test for normality using SPSS. The data did not follow a normal distribution on early testing, so a Wilcoxon test was completed and was significant, so there was evidence to show a difference in percentage of weight loss between the interventions. The sample is large, continuous, and the data is not skewed to any direction. So they resemble normal distribution, just with thicker tails. So we were able to use them as approximately normal and use t-tests to compare the weight loss data using percentage of weight loss. Paired t-tests were then used to evaluate blood pressure and heart rate, and then reported energy levels and appetite control were evaluated at baseline after 3 months of diet and exercise, and then again after 3 months of diet, exercise, and phentermine use. And chi-square tests were completed to compare whether the differences in answers with interventions were significant at that point. The participants' weight decreased with both interventions, but more weight was lost during the intervention with addition of phentermine. An average of 1.6% of the participants' body weight was lost after 3 months of diet and exercise alone, and an average of 6% of the participants' body weight was lost after 3 months of diet, exercise, and phentermine were used. When evaluating blood pressure for participants between the interventions, the difference in blood pressure after diet and exercise for 3 months compared to the starting blood pressure is significant, but the addition of phentermine does not have much further effect at that time. When the heart rate was evaluated through the interventions, there was a slight change in heart rate, but otherwise no difference between the groups. As participants were asked about their energy levels throughout the intervention, 79% of the participants reported good energy levels after the intervention using diet and exercise and phentermine, whereas only 15% of participants reported that energy levels were good after intervention of diet and exercise alone. The participants reported appetite control resulted in 7% of the participants reporting appetite control after the intervention of diet and exercise alone, but there was a significant increase in appetite control reported with the use of diet, exercise, and phentermine as the intervention at 87%, showing a highly significant difference in appetite control with the addition of phentermine, proving that phentermine works well for appetite control. Though this scholarly project had many strengths, there were also some limitations to this project that may have affected data collection and patient outcomes. One limitation may have been the sample. After 417 charts were reviewed, only 100 participants were identified as appropriate for the sample. The sample size was adequate, as we know the higher the sample size, the more the validity increases and is more representative of the population. But the fact that it is a convenience sample can create some limitations. The sample was increased to 100 participants to improve validity, but the limitation of the convenience sample can still affect the data outcome. In the sample study, there were 68 females and 32 males. This can also cause bias in the outcome data, as we know men and women lose weight at different rates based on muscle acquisition. This was not differentiated or accounted for when reporting the data for the study. Participants also met with a dietitian at the beginning of the program and were instructed on a specific diet based on their needs. And although a major part of the intervention, as was the diet, a limitation based on the diet could have been compliance to following the diet. To minimize the limitations, the participants were prescribed the diet and educated on this, but data on how closely the participants followed the diet was not collected. Each participant may also not have had the same accessibility to healthy food options or ability and time to cook, and this was not factored in during the data collection, but was expected that they work on following the diet set throughout the program. Another limitation to the study was the control and monitoring of exercise. Participants were prescribed a specific exercise regimen based off their orthopedic needs to minimize limitations. For some participants, this could have been a very rigorous exercise regimen, and for others, this may have been minimal exercise based on their needs, but this can impact calorie expenditure and muscle acquisition, which can change weight loss outcomes. Although participants agreed to exercise throughout the program and were given tools to follow the regimen, the participants' compliance with exercise was not monitored, so this may have also changed outcomes depending on how this intervention could have been monitored differently. Another evaluation that was not conducted at the beginning of the program was a psychological evaluation. We did incorporate exclusion criteria for participants that specified that any individuals who have history of eating disorders were excluded from the study, but participants could have benefited from psychological evaluation to further evaluate eating behaviors that may impact their ability to follow their prescribed diet. Some individuals may struggle with eating behaviors affected by stress, emotions, habit, or even celebratory eating behaviors. This can be difficult to change despite a decrease in appetite. This can not only make a difference in the outcome data of the study, but the sustainability of weight loss for participants. If these behaviors are not addressed, it can be very difficult to create sustained weight loss and maintenance. The results of this scholarly project show that the intervention conducted with diet, exercise, and phentermine use resulted in more weight loss, no increase in blood pressure or heart rate, improved energy levels, and improved appetite control. This supports the change in practice to use anti-obesity medications such as phentermine in combination with diet and exercise to improve weight loss with treating obesity. This is a multifaceted approach to treating obesity, but can make a greater impact on decreasing associated risk factors leading to comorbidities. Previous studies utilizing phentermine for treatment of obesity are limited due to perceived barriers in treatment, while this project evaluated weight loss, blood pressure, heart rate, reported appetite control, and reported energy levels. The results of this project provide data to support interventions for treatment, but also can increase education opportunities, decrease barriers to perception of obesity management, and improve comfort levels of healthcare professionals when approaching the need for intervention with obesity treatment. The data obtained in this project can make an impact in nursing practice by helping to decrease barriers to obesity treatment and practice and recognizing obesity as a disease needing management. This can start with assessing for risk factors in the practice setting, such as measuring BMI at every visit, to determine if the patients would benefit from obesity treatment. In following the American Association of Clinical Endocrinology clinical practice guidelines, pharmacotherapy should be initiated as an adjunct to lifestyle changes for obesity treatment and should be considered for patients with a BMI of greater than or equal to 30 and also patients with a BMI of greater than or equal to 27 with weight-related comorbidities. Data on patient outcomes from this project can provide education for providers, but also work to develop additional research on other medication interventions for weight loss. The benefit to all patient care will be the opportunity to decrease barriers to treating obesity through additional research interventions. The success of studies such as this project help to direct future research targeting obesity as a disease and the possibility of adding pharmacology in patients with obesity. Ongoing clinical studies, as well as research of previous and current practice, will determine efficacy and safety of anti-obesity medications as part of a multifaceted approach to obesity management. The results of this scholarly project show that the intervention conducted with diet, exercise, and phentermine use resulted in more weight loss, no increase in blood pressure or heart rate, improved energy levels, and improved appetite control. Results show that the anti-obesity medications such as phentermine can improve weight loss compared to diet and exercise alone. And as the prevalence of obesity continues to increase, treating obesity with a multifaceted approach to include anti-obesity medication can decrease associated risk factors that lead to comorbidities. As advanced practice nurses and advocates for our patients, it is essential that we lead in change for improvement of treatment and work collaboratively as a healthcare team to treat obesity as a disease. The results at the conclusion of this project provide data to support interventions for treatment, to increase education opportunities, decrease barriers to perceptions of obesity management, and improve comfort levels of healthcare professionals when approaching need for interventions with obesity treatment. In conclusion of my presentation today, I leave you with this. As advanced practice nurses and as advocates for our patient, and as it is essential that we lead for this change and the improvement for treatment and work collaboratively as a healthcare team to treat obesity, I encourage you to look at ways you can improve your practice to improve the outcomes for this patient population. I sincerely appreciate your time today and your attention, and I welcome any questions you may have. Thank you.